Thank you for joining us for today's webinar, Digital Health and the Changing Paradigm of Atrial Fibrillation Treatment. We're going to give people a minute or so to log on and get started shortly. Okay, I think we're going to get started. Thank you again for joining us today for our webinar titled Digital Health and the Changing Paradigm of Atrial Fibrillation. My name is Kathleen Krasnowski, and I'm the Director of Development for Feinberg School of Medicine. And I've had the pleasure of working closely with Dr. Passman for the past 8 years. We are all in for a big treat today as we learn more about this fascinating and emerging landscape. I'm pleased to introduce our speaker, Dr. Rod Passman. Dr. Passman has called Feinberg School of Medicine his professional home for the past 25 years and is professor of medicine in the Division of Cardiology and Preventive Medicine. A world-renowned expert, he is director of the Center for Arrhythmia Research and the Jules J. Reingold Professor of Electrophysiology. We have a robust group on our call today. We're so thankful that we've got medical school alums and friends of Northwestern. We hope you enjoy the presentation. We'll have plenty of time at the end for questions and answers. We totally appreciate some of the questions that have been submitted ahead of time. And if you would like to submit a question during the chat, please go to the question and answer button at the bottom of your screen. You may also use closed captioning if you click on the closed captioning button at the bottom of your screen. Thank you again for participating. And now I hand it off to Dr. Passman.
Good afternoon, and Kathleen, thank you for that very kind introduction. Before I begin, 2 things. I want to temper expectations a bit. I mean, atrial fibrillation is a huge topic. There are textbooks written about it. There are journals dedicated to it and full conferences. So I'm going to focus my talk on how digital health is affecting how we detect and manage this disease. But I'm going to leave plenty of time for questions and answers to tackle other things. Kathleen told you a bit about me. Let me just add to it. This is the first and only job I've had at a fellowship. In case you cannot tell, I do not have a Midwestern accent. I'm from New York originally. My wife and I came here 25 years ago. She is also a physician. She's the vice chair of medicine. And we expected to stay here for 2 or 3 years, and that was 25 years ago. In my time here, I've seen unbelievable change. When I first joined the faculty, the cardiology division was pretty small. And in a 25-year time frame, we've grown exponentially. We now have really not only a national footprint, but an international reputation as sort of leaders in cardiovascular care. So it's truly been my privilege to be part of this organization. So I'm going to make a grand assumption that there are only maybe a handful of people on the call who are cardiac electrophysiologists. So for everyone else, let me start with a little background. In case you didn't know, atrial fibrillation is the most common sustained abnormal rhythm in adults. The prevalence is really unknown because we don't know how many people have atrial fibrillation. We think that number is between 2.5 and 7 million. But because this is a disease of aging, because this is a disease of patients who have things like high blood pressure and diabetes, which are also rising in incidence and prevalence. That number is expected to exceed 15 million by the year 2050. Now, if you're a 40-year-old male or female and fortunate enough to live till the 8th decade of life, you have between a 1 in 4 and 1 in 3 chance of developing AFib in your lifetime. And what's interesting about atrial fibrillation is it is such a heterogeneous disease. Some people feel every moment that they're in atrial fibrillation, they feel palpitations, they feel shortness of breath, they feel lightheadedness, they may feel fatigued, and some people are completely unaware that they have atrial fibrillation. Atrial fibrillation also comes in several forms. In the paroxysmal form, these episodes come and go on their own, typically lasting several hours or several days. In the persistent form, it typically lasts several weeks. And there are those with permanent atrial fibrillation, who are in atrial fibrillation all of the time, either because we cannot get them and keep them in a normal rhythm, or we've not even tried to do so. But whether you feel your atrial fibrillation or not, we know that AFib has tremendous consequences on our health. It can lead to heart failure, dementia, and premature death. But perhaps the most devastating consequence of atrial fibrillation is that 3 to 5-fold increased risk of stroke. Now, how we understand the relationship between atrial fibrillation and stroke is really an interesting history. If you go back more than 200 years, looking at the University of Edinburgh, William Wood first described a ball thrombus in the upper chamber of the heart, the left atrium, in someone who had rheumatic fever and had what's called mitral stenosis, which is a closure of one of the major valves of the heart. Several decades later, they recognized that these clots can break off and go elsewhere, including the brain. And then in an autopsy series about 100 years ago, they determined that these blood clots were more common in those that had what they called auricular fibrillation, which we would call atrial fibrillation today. And in 1942, this landmark study out of Boston showed that older age and the presence of auricular fibrillation were independent risk factors for blood clot formation. Now, why people with atrial fibrillation are at increased risk of stroke, I think is shown well in this video. If you think about it, in a normal situation, when the heart is beating in a beautifully coordinated manner, the blood rushes through the heart in a highly organized manner. But in atrial fibrillation, the upper chambers of the heart are now beating very irregularly and rapidly, and blood stagnates in those upper chambers. And that blood can form a thrombus or clot. That clot can leave the upper chamber and travel to the lower chambers of the heart, where it's then ejected through the major vessels to the brain. As I mentioned, these are relatively large clots. They may be the size of your fingertip. And as they travel down the vasculature of the brain, ultimately the blood vessel is going to be smaller than the size of the clot itself. So if that clot starts to obstruct blood flow in the brain, depicted here in this black area, all of that brain tissue that's supplied by that blood vessel is going to die, unless we open it up or give a blood thinner rapidly to dissolve that clot. This can cause irreversible stroke, and those strokes, as I said, tend to be severely debilitating or life-ending, much more compared to other non-afibrillated strokes. So how do we know that anticoagulants, some call them blood thinners, how do we know that those are an effective strategy to reduce the risk of stroke? Well, for that, we would need to go back to the 1920s. And something really interesting happened. They used to, in North America and Canada, feed cattle cloves, and they still probably do today. But during moist periods of time with a lot of rain, some of those cloves would become spoiled, would become moldy. When economic times were good, they would never feed those moldy cloves to the cattle. Where economic times were bad, like in the 1920s, they were forced to feed the cattle those moldy cloves. And some of those cattle developed what's called a hemorrhagic fever. They essentially bled to death. And some call that sweet clover disease. Now, fast forward to 1933. A farmer working in Wisconsin named Ed Carlson had one of his cattle die from this hemorrhagic fever. So he put the cattle on the back of his truck, along with a bucket of blood from the cow that failed to congeal. And he drove to the University of Wisconsin and gave the cow and the bucket of blood to Carl Link, along with a sample of the cloves. And Carl Link was a chemist who spent the next 6 years figuring out what was in those cloves that prevented blood clots from forming in that cattle. And he isolated the substance called 3,3-methylene bis 4-hydroxycoumarin. But because he worked at the University of Wisconsin, he patented this chemical and called it warfarin, standing for the Wisconsin Alumni Research Foundation. And actually, the sale of warfarin, right, subsidized the University of Wisconsin for decades. Now, as many of you know, right, this substance was first approved for use as a rat and mouse killer. What would happen is the mice or the rats would eat the Coumadin. It apparently makes them thirsty, so they leave your home and they bleed to death outside of your home. In late 1951, a young Army recruit tried to commit suicide by ingesting warfarin, and nothing happened to him, leading to the thought that maybe this was safe to use in humans. And indeed, 3 years after it was approved as a rodent killer, it was approved for use in human beings. Now, the drug did not get a lot of notice until 1955, when Dwight Eisenhower suffered a large heart attack. And the feeling was if we could thin his blood and prevent blood clots from forming in the coronary arteries, that might be good for coronary disease. So this was the first sort of widespread public recognition of the potential use of this medication. Now, it took the Framingham study, which some of you may have heard about in the 1970s, to show that people with atrial fibrillation are at increased risk of stroke. And it took the late 80s and up until 1991 till we showed that people treated with warfarin or Coumadin, right, who have atrial fibrillation, can reduce the risk of stroke, right, cementing the concept that anticoagulation or blood thinners are useful at reducing the risk of stroke in patients with atrial fibrillation. Now it gets a little complicated because not all patients with atrial fibrillation are at equal risk of stroke. It turns out that you need to have other risk factors combined with atrial fibrillation to really warrant the use of anticoagulation. So today we use a scoring system called the CHADS-VASc scoring system. On the left is the scoring system that we use. We essentially look at your vascular risk factors. We look at your age. We look at whether the pumping function of your heart is normal, whether you have hypertension, diabetes, prior stroke. We know that women are at higher risk than men, and we want to know if you have things like peripheral vascular disease. And we add up your points, and the points go from 0 to 9. And then we look on the right-hand side, and we try to estimate your yearly risk of stroke. In general, we recommend anticoagulation when you have 2 or more points. So a CHADS-VASc score of 2 or more, we generally recommend oral anticoagulation. And the good news is that these medications are among the most successful drugs in all of medicine. Right? Anticoagulation reduces the risk of stroke by about 65%. However, anticoagulants also prevent blood clot formation when you need to clot the blood. So they are associated with some significant risks. And anticoagulants, while they reduce the risk of stroke, are associated with a risk of major bleeding of 2 to 4% per year, minor bleeding of 14 to 18% per year. And as a result of these real or perceived risks, only about 2/3 of patients who might benefit from being on an anticoagulant actually are ever prescribed it. And about half of those patients who are prescribed oral anticoagulation stop within a year or two. Now, over the last decade or so, we have 4 new drugs called novel or direct oral anticoagulants, and you may have heard the term NOAC or DOAC. And these drugs listed here, Pradaxa, Xarelto, Eliquis, and Savaysa, I think have clear advantages over Coumadin. Number one, you don't need to check your blood thinning level like you do in Coumadin. Number two, they don't interact with other medications very much, and they don't interact with food. So people on Coumadin typically cannot eat dark green leafy vegetables because they contain vitamin K, which can reverse the effects of Coumadin. That's not true with these NOACs or DOACs. And in general, they may reduce the most serious types of bleeds compared to Coumadin. The downside is the cost. And if you have to pay out of pocket, these drugs can be significantly more expensive than the standard Coumadin that we've been using for decades. So let's pause for a moment, right? We have a disease that we know has huge health implications. We have a disease that is common, particularly as we get older. But we have a disease that may be clinically silent and may come and go. So how do we detect atrial fibrillation if you, as the patient, can't tell us that you're having atrial fibrillation? And the answer comes that we need to record what the rhythm of the heart is doing. Now, we've known about irregular pulses since the ancient Chinese and Egyptians thousands of years ago. But it took William Einthoven in 1895 to invent the first quote unquote practical ECG machine shown on the far right. And this would allow us to record the rhythm of the heart. But there's a problem here too, because if this disease comes and goes, if you happen to not be in it when your doctor is examining you or recording your ECG, how would we know if you're having an abnormal rhythm? For this, we need remote monitoring, right? A monitor that allows you to see what's going on with the rhythm of the heart outside the hospital setting. This is a gentleman named Norman Holter. Norman was not a tinkerer, was not a physician, he was a tinkerer. And he was interested in designing a device that could indeed monitor the rhythm of the heart outside the hospital setting. The good news is that Norman was successful in his quest. The bad news is the device shown here weighed 85 pounds, had to be carried on your shoulder with a series of belts and straps, and can only record the rhythm of the heart for 24 hours. But for the first time, we could try to detect abnormal rhythms, right, when you're not in the hospital and you're not hooked up to an ECG machine. So today we have a whole plethora of devices that can monitor the rhythm of the heart outside the hospital setting. On the far left are the devices that we use in medicine every day, right? This is a patch technology shown here. You could place this on the chest. It can record the rhythm every minute of the day for a week or two, and you could send that patch in and get the information downloaded. Below it is a more standard Holter monitor. These little electrodes are connected to the chest wall by little adhesive tape. And this too can record the rhythm of the heart and actually transmit the data to a call center to see if you're having episodes of an abnormal rhythm, even without having to send the device in itself. In the middle are these implantable devices. And it's important to note that the current generation of pacemakers and defibrillators can detect all episodes of atrial fibrillation, record it in its memory, and using remote transmission, send it to us and tell us that you're having an episode of some abnormal rhythm or the other. Below are what's called insertable cardiac monitors. These are incredible devices. They're about the size of a small paper clip. They're small enough to be injected underneath the skin just to the left of the breastbone. And these too record every minute of the heartbeat, save the abnormal pieces of rhythm in its memory, and using Bluetooth technology, transmit that data through a bedside transponder to me as your caregiver. So no matter where in the world you are, right, through this tiny chip that lasts several years, we can know if you're having an abnormal rhythm of the heart. On the far right, to me, are the most interesting. And those are digital health technologies. And I say this because for the first time, right, a consumer can go into a store and go online and buy a device for a relatively small sum of money that could tell them if they're having an abnormal rhythm of the heart. So how do we use this technology to detect and manage this disease? Well, first, let's take a step back, because some have said that the first reported example of a wearable heart rate monitor was actually done in the 1700s by this gentleman, Sir John Floyer. But I actually read this paper, and really what he was describing was a second hand, which would allow a physician to check your pulse, count your heart rate, and detect what your heart rate would be in a minute. On the far right is the true first wearable heart rate monitor. This was invented for the Swedish ski team during the Olympics, and they used this for training purposes. So this was the first example of a wearable, digital, accurate heart rate monitor. So how do we then expand this technology, right, to really figure out who has atrial fibrillation and how best to manage those individuals? I believe that the future of atrial fibrillation monitoring will be smartphone-based. This is a picture of the Pope's inauguration in the year 2005. If you look very closely at the bottom right-hand corner, there's one individual who has a device capable of taking a picture and making a phone call. This is that same exact scene 8 years later. There's not one person in the audience who does not have a device capable of taking a picture and making a phone call. In fact, there are more cell phone accounts on the planet than there are human beings. And now almost 90% of the US population owns a smartphone. So how do we leverage this technology to take better care of people? Well, I show you here the spectrum of devices available. On the left are devices based on what's called photoplethysmography, or PPG. On the right are devices that you could actually record an ECG, and those are either handheld devices. Some of those are not available in the United States. And on the bottom are smartphone-based devices, of which are available. And then in the middle, you have devices that blend both technologies. And let me take you through both of these. So PPG, or photoplethysmography, has been around for a very long time. It's relatively easy to do. It is relatively inexpensive, and you can include it in everything from pulse oximeters to clips in the ear. And essentially what it does is it uses a light source and a photodetector to determine changes in light intensity on the skin surface. And we know that those changes, right, correlate with the amount of blood being pumped out of the heart with each heartbeat. And if we can figure out, right, how much or how regular the heartbeat is, then we can decide whether someone has atrial fibrillation, which looks like the chaotic rhythm above, or a more organized rhythm consistent with sinus rhythm. While this is a relatively ubiquitous technology, again, very inexpensive, easy to do, there are problems with it, right? It's a hard thing to distinguish one squiggly line from the other. It's very susceptible to motion artifacts. So when you're working out, for example, it may not give you a very accurate reading. But there are very plentiful examples of the use of this technology. You can download an app on your phone, which allows you to put your finger up to the lamp, and it will record a 30-second PPG, and the algorithm in the phone will tell you whether you're in a normal rhythm or atrial fibrillation. Most of the smartwatches that we wear that are heart rate monitors of any sort have PPG to tell you what your heart rate is during the day and during exercise. And some of you may even own this ring. It's called an Oura ring, and it too has a PPG light that goes on and is a pretty accurate measure of what your overall heart rate is. But most of us are not going to make a diagnosis of atrial fibrillation based on the squiggly lines I showed you. We need to see an electrocardiogram. And you could turn your smartphone into a ECG machine very easily. I'm a big fan of this device called Cardia. The current generation is literally the size of a credit card. You could put your fingers on the device, and it uses high-frequency ultrasound to send that data to your smartphone. And the smartphone will record the ECG shown here, and will read it in real time and tell you whether you're having atrial fibrillation or normal sinus rhythm. And on the right is a more sophisticated version. Not only do you touch the sensors with your fingers, but on the back is another sensor that you put on your ankle or your leg. And this could record a 6-lead EKG, which is closer to what we do when you go to your doctor's visit. And this may be more beneficial in certain circumstances. So these are technologies that are relatively inexpensive and can allow the consumer to record and discern whether indeed they're having atrial fibrillation in the privacy of their own home. Now, the blended technologies are typically the smartwatches that we have. And whether it be Apple or Samsung or Fitbit, all of these technologies combine PPG with the ability to record a single lead ECG by touching the crown of the watch. So let me give you a bit of history of why we have this. Several years ago, Apple was interested in designing a very, very accurate heart rate monitor. So if you have one of these devices, you'll notice that these green lights go on during the day, and particularly when you're working out. And this is how it measures the heart rate. And what happened was that people started to write letters to Apple saying that the Apple Watch, quote unquote, saved my life, because the Apple Watch told me that my heart rate was rapid when I wasn't doing anything. And when I went to my doctor's office, they told me that I had atrial fibrillation, which I never would have known about. So Apple thought, well, if we could detect the heart rate, then we can detect the heart rhythm. So they incorporated this feature called irregular rhythm notification. And what this does is throughout the day, if this feature is activated, it will try to detect your pulse every 2 hours or so. If the pulse is regular, it will then check again in 2 hours. If the pulse is irregular, it will start checking the pulse every 15 minutes. And if that irregular pulse goes on for an hour or so, it will give the wearer a warning that they're having an irregular rhythm, and they may want to record an ECG or seek medical attention. So how accurate are all these devices that I'm showing you? And the answer is it depends. Depends what manufacturer, depends how you wear it, it depends on many other features. I will tell you that I think these are incredibly powerful tools, but that most of us would not base a clinical decision solely upon the information we get from one of these devices. But it could give us the information we need to confirm the diagnosis of atrial fibrillation, or in some cases to disagree with what the watch says and confirm indeed that you don't have atrial fibrillation. So how do we use this technology to better improve the health of the population? One is to perhaps screen the population for atrial fibrillation, right? We have a disease that's common. We have a disease that may be clinically silent. We have a disease with potentially devastating consequences. Could we find atrial fibrillation early in people who don't even know they have it, get them on an anticoagulant, and improve their lives and the risk of stroke? So there are several studies that have looked at this, some using PPG, like the Digital AF trial, some like the Vital AF, Search AF, or Rehearse AF, have used these devices in different settings, like Search AF looked at anyone over the age of 65 coming to their pharmacy, for example. And I would say in every study, we find more atrial fibrillation than if we don't look, right? That makes perfect sense. What we've really yet to prove is that finding atrial fibrillation early and getting these people on anticoagulants reduces the risk of stroke. That's a much higher bar to set. Those studies need to be very large and follow people for long periods of time. I am involved in a study called Heartline. This is a study where we're taking patients over the age of 65. Half will get standard of care and half will get a Apple Watch, right, capable of detecting episodes of atrial fibrillation. This study now has enrolled about 26,000 people. We're following these individuals up, and I think this will answer the question, does the early detection of atrial fibrillation allow us to not only find more atrial fibrillation, but impact those things that we care about, like stroke risk, heart failure risk, and premature death? So let me tell you, though, that the future of atrial fibrillation monitoring is well beyond a wearable device. There are sensors that one can put in their mattress that measures what's called ballistocardiography, small changes in chest wall movement that occur with each heartbeat. And it can discern normal sinus rhythm from atrial fibrillation just by you sleeping on the mattress. There's something called facial PPG, where there are small perturbations in facial coloring during each heartbeat. And by videotaping a crowd, we could pick out from the crowd who is in atrial fibrillation and who is in a normal sinus rhythm. There are smart speakers that will collect the sound waves that bounce off your chest and can also separate who has sinus rhythm from who has atrial fibrillation. And when you're in atrial fibrillation, there are slight changes in how you pronounce certain vowels that can also be detected. So from talking on the phone, for example, we could define who is in atrial fibrillation. So maybe in the future, right, our cars will have PPG and ECG devices on the steering wheels. Our seats will have ballistocardiography. The speakers will collect the information from the music bouncing off your chest. And every time you look in the mirror, we'll measure PPG. So if we don't find your atrial fibrillation while you're wearing your watch, while you're sleeping on your mattress, while you're looking into a camera, while you're listening to music or talking on the phone or driving in your car, rest assured there are now toilet seats out that can monitor the heart rate, blood pressure, and heart rhythm. So I think that the best use of this technology actually is not in screening, but in how we manage this disease. What I didn't tell you about the CHA2DS2-VASc score is that if you apply this scoring system to the US population with atrial fibrillation, 80+% of people would be indicated for a lifetime of oral anticoagulation. And I want to emphasize that word lifetime, because once we start oral anticoagulation, in general, we do not stop it unless there's a clear reason to do so. So we sort of have a one-size-fits-all approach when it comes to anticoagulation. If someone has a CHA2DS2-VASc score of 2 or more, which could mean you're 65 years of age and have high blood pressure, very common, right? You are on the same dose of the same anticoagulant for the same duration as someone with a CHA2DS2-VASc score of 8 or 9. To make that worse, right, it has no regard of how much atrial fibrillation you have. So someone with a CHA2DS2-VASc score of 8 or 9 with multiple risk factors for stroke, who may be in chronic atrial fibrillation every minute of the day, right, every day of the week for 365 days, those patients are on the same anticoagulant as those on the bottom left, right, who have very borderline risk factors and may actually have infrequent episodes of AFib or even absent episodes of atrial fibrillation, either on their own or as a result of lifestyle modification or a result of antiarrhythmic drugs or as a result of ablation. So how many diseases are there where we continue to treat patients even when the disease is gone? The problem is that we have no cures for atrial fibrillation. Even ablation sometimes fails. And if you don't know when you're having atrial fibrillation, how can we safely stop the anticoagulant when your first sign of a recurrent episode isn't a stroke? So my question is, can we take these patients, right, who have little or no further episodes of AFib for the reasons I mentioned, who have maybe a limited number of risk factors, and move away from that one-size-fits-all model, where we give them a personalized approach, stop anticoagulation, monitor them intensively, and treat them with some have called a pill-in-pocket approach to anticoagulation, right? We only give them anticoagulation if they've had a prolonged episode of atrial fibrillation. We only give it for a few weeks, right? And in doing so, we could minimize the exposure to the risks of these medications while still maintaining effective stroke prevention. So how do we do this? Well, I mentioned earlier that we can do this with pacemakers or implantable monitors, right? We can get the data from these devices, and we could let the person know if they're having an episode of atrial fibrillation. The problem with that is that these devices, first of all, are invasive. These devices are very expensive. Most people don't need a pacemaker or defibrillator. And the use of an implantable monitor for this indication, right, is not scalable because it would require a team like we have at Northwestern to remotely receive that data, right, adjudicate the event, and call you on a weekend or a holiday to let you know if you're having an episode of atrial fibrillation. These devices are not at the place yet where they're alerting the patient that they're having an abnormal rhythm. Right now, they alert the healthcare team that you're having an abnormal rhythm. But in the early days of this concept, we didn't have a choice. So we did 2 pilot studies, one on an NIH grant called React.com, where we used an implantable cardiac monitor. And on the right is a study called Tactic AF, where we did use patients with pacemakers and defibrillators. And these were really proof of concept pilot studies. But what we learned was really quite critical, because combined, we found that using this pill-in-pocket approach, this personalized approach to anticoagulation, that we could reduce the time on the anticoagulants, the blood thinners, by about 85%. And there were no strokes in either group, suggesting that this approach is feasible. What we don't know is it safe? And how do we scale this to the tens of millions of people around the world who may be eligible for this approach? Well, here comes another story. Because as I mentioned earlier, right, you can have a watch that could sense episodes of atrial fibrillation. The problem is that the watch that you would buy in your store is really not designed to be incredibly sensitive for short episodes of atrial fibrillation. It's fine for the average person, but if we're going to make decisions about going on and off a blood thinner, that's not going to do the trick. So several years ago, we approached Apple with this concept, and we've had the opportunity to work with them over several years to take the current generation of the Apple Watch and to turbocharge it. So basically what we're doing is having it check the pulse every 15 minutes. And we're using a special research platform called Eureka, designed at UC San Francisco, to take the information from the Apple Watch and alert the individual in real time that they're having a prolonged episode of atrial fibrillation. And this is a very complicated picture, but essentially we're combining these 2 algorithms. The algorithms do use artificial intelligence to read that PPG signal coming off the watch. And the sensitivity and specificity is in the high, 98% range. So this is what it would look like. A patient who would otherwise be on an anticoagulant 365 days a year would stop it. Their watch would monitor the rhythm of the heart. It would alert them if they've had a multi-hour episode of atrial fibrillation. If they want to, they can confirm the AFib on their watch, but it's not necessary. The watch will then remind them to restart their previously prescribed oral anticoagulant and to take it for the next 30 days, and then stop. So a patient who has an episode of atrial fibrillation every 29 days is never going to get off their anticoagulant. A patient who has one episode of atrial fibrillation a year would only need to be on their oral anticoagulation 1 month out of the year. So the study that we're about to start is called REACT-AF. It stands for Rhythm Evaluation for Anticoagulation Therapy for Atrial Fibrillation. This is a randomized trial, which means half of the people will stay on their currently prescribed oral anticoagulant, and half will get this customized smartwatch, right, and get this watch-guided approach to oral anticoagulation. Our goal is to show that this new approach is just as good as the old approach of being on chronic blood thinners in terms of preventing stroke, preventing other blood clots from forming in the heart, and all-cause mortality. But because your need to take the anticoagulant will be significantly reduced, we expect to have a major reduction in major bleeding events by at least a third. The study will enroll up to 5,350 patients at 80 to 100 US sites with a follow-up of 3 to 5 years. And I'm very proud to say, after 12 years of development, last August, we received an NIH grant worth $37 million to pursue this clinical trial. And we're very excited that enrollment will be beginning at the end of June of 2023. So I want to just focus on how you get into this trial, because this is not for everyone. We're focusing in on a low-risk population, individuals with a CHA2DS2-VASc score of 1 to 4 who've not had a prior stroke or a transient ischemic attack. People who are coming to us for the trial should be on a oral anticoagulant, not Coumadin, but one of those new drugs. And they will have a 50-50 chance of being taken off of it, but with this safety net in place. And while we're giving people this turbocharged smartwatch, you need to own an iPhone that's compatible with the watch, which we're not able to provide. And you need to be willing to wear that smartwatch at least 14 hours a day. In terms of exclusion criteria, we're excluding those individuals who have pacemakers and defibrillators, or may need one in the near future. And we want to purposely select for those individuals who have very few episodes of atrial fibrillation. So you will have to wear a patch like the technology I showed you, and that patch show no episodes of AFib lasting an hour or longer within a few months of enrollment. So another little historical tidbit, watch faces have something on it called complications. And they're called complications because in the early days of watch design, anything on your watch beyond those hands that told time were complicated. And therefore, even in today's digital watches, all of those features beyond the time issue are called watch complications. So we'll be building our own watch faces and watch complications for the REACT-AF trial. It will alert you when you're having an episode. It will tell you when to start your oral anticoagulation. It will go into your calendar and remind you how many days to take it. And if you don't recognize and you don't acknowledge these warnings that you're going to get on your phone and your watch, you're going to be in trouble, because we're going to send you more and more push notifications. We're going to send you SMS texts. We're going to start robocalling you. And then a human being is going to call you, because we want to make sure that there's a safety net in place, and that if you're having an episode of atrial fibrillation, that you're restarted on your oral anticoagulants as soon as possible. One other cool thing about this trial is that because all of these individuals in the trial need to have a smartphone, the only time you're going to see the study coordinator is at the time of enrollment. All of the follow-up is done remotely. There will be questionnaires sent to your smartphone. Your smartphone will know when you've been hospitalized and get us those medical records. And therefore, I think this is also a big step forward in the way we should be doing research to make it much more cost efficient in the digital era. I want to note that this is not something that one does alone. While I'm the principal investigator of the trial, and Northwestern is the center for the clinical coordination of the trial, we're working with a team at Johns Hopkins for the data coordination. We're working with teams at Stanford for some of the site development. And as I mentioned, we're working with teams at UC San Francisco for some of the technology issues. For those of you who want to learn more about this trial or want to enroll, the project manager is named Lauren Keene, and her email address is shown here. I want to also acknowledge the support that we've gotten from the National Institute of Health, the Northwestern University Clinical and Translational Science Institute, and the Trial Innovation Network. And then for the role that the American Heart Association is playing in helping with this study, as well as the in-kind support from Apple. So what are the implications of this trial? Well, I think it's a huge step forward in personalized medicine, right? We're not just treating risk factors, we're treating individuals, and everyone should be treated differently. It's not a one-size-fits-all disease. Ultimately, I hope that we can reduce the time on anticoagulation, and in doing so, reduce bleeding, reduce costs, and improve quality of life. I want to finish with this quote from the New York Times. It says, the notion of allowing patients to test themselves and treat themselves is outlandish to most doctors. Let me remind you, this was not written in the year 2023 in response to what I am suggesting. This was written about 100 years ago when this medication came out. So with that, I'll thank you very much for your attention and open it up to any questions.
Thank you so much, Dr. Passman. Like I said, I've been working with you for 8 years now, and every time my mind gets blown away with what you're doing. So thank you. The first chunk of questions we've gotten, they're all about AFib and treating AFib. So the first one, when do you consider someone for an ablation? And how successful are ablations for treating AFib?
So those are great questions. I mean, this whole field of ablation did not exist 25 years ago. This is all new. And ablation, where we go into the heart and try to disrupt the circuits causing atrial fibrillation, has really come a long way. We generally reserve ablation for people who are bothered by their atrial fibrillation, who are symptomatic from their atrial fibrillation. People who are younger, and younger is, objective, also may be a candidate for ablation, whether they feel it or not. And often we may try medications first, but if medications aren't tolerated or don't work, certainly ablation is reasonable. We have a really busy ablation program, and I think we have outstanding electrophysiologists. There are 9 of us. I would say the success rate is somewhat dependent on a lot of other factors, right? What other risk factors you have, how long you've been in atrial fibrillation. And we generally quote success rates of around 75%. But I will tell you, when we do monitoring on patients with atrial fibrillation, even if we don't cure them altogether, we may reduce the amount of atrial fibrillation by about 99%. So I think that cure is a tough thing to achieve, but in many cases, we can favorably impact how much atrial fibrillation you're having in a relatively safe and quick procedure.
Oh, thanks. And then another way of treating AFib, somebody wrote in and asked about the Watchman device. Can you tell us about that, please?
Yeah, so I talk about stroke prevention, and anticoagulation is sort of the cornerstone of therapy. But in those individuals who are at high risk of stroke, who are also at high risk of bleeding on these medications, there are 2 FDA-approved devices. One is called Watchman and one is called Amulet. And these are essentially plugs that can be placed in the upper chamber of the heart through tiny punctures, sites in the groin. And these essentially wall off the areas where the blood clots form. So these may be a viable option for patients who, again, should be on anticoagulation because of AFib and stroke risk factors, but have either demonstrated the inability to take it because of bleed risk or felt to be too high of a bleed risk to be on a long-term anticoagulant.
And talking about all these different treatments, somebody asked about what are the long-term effects of AFib treatment on the heart? And then they asked, the follow-up would be the REACT AFib study, will it address idiopathic AFib, and then will it also address the flutters?
Right. So great question. So I would say, we know that drugs that we give, obviously every drug has side effects, and drugs that are designed to influence the rhythm of the heart can have some serious side effects. Most of those side effects are reversible, but that too is a reason why we consider ablation a really viable option, because it avoids the long-term consequences of being on medication. In terms of ablation, we've been doing it for 25 years, and we don't believe that there's any long-term negative consequences. In fact, the opposite. It appears that keeping people in a normal rhythm may have a lot of favorable impact on the risk of heart failure, maybe the risk of stroke, maybe the risk of dementia. We're really not sure. but it only does favorable things as far as we can see so far. Yes, REACT-AF will deal with what's called idiopathic AF, which we really call lone atrial fibrillation. These are typically people who are younger, who don't have a lot of risk factors for stroke. As said, you need to have at least one risk factor. So generally, you'd have to be over the age of 65, or at least have a risk factor like high blood pressure. But we are agnostic to why you have atrial fibrillation. And we want to make this study generalizable. This is not just for patients who have had an ablation done. This is for all comers with atrial fibrillation.
Great. And one question that just came in that's pertinent to our topic here is bringing in the discussion of COVID. Did you feel COVID or vax have spiked cases of AFib?
Boy, that's a great question. I mean, there certainly was concern about it early on. You know, we know that any viral illness or any illness can increase the rate, but we didn't really see a huge influx of atrial fibrillation in your average COVID patient. And yes, I mean, you know, so many people got vaccinated, and some people said my AFib began afterwards. I've not yet seen convincing studies to say there's a cause and effect. And, you know, all diseases start at one point. So I think that again, we've not seen a spike in the number of cases, but there's certainly a lot of interest in correlating those two.
Great, thanks so much. And then another question, what dietary elements increase or decrease the likelihood of atrial fibrillation besides obesity? And then the other question is, somebody must love coffee. Is coffee protective in any way or helpful?
Well, those are great questions. I think we're recognizing that there are a lot of lifestyle choices that may impact your risk of AFib. So, you know, certainly not getting obese is important. Exercise is important. Getting good night's sleep is important. If you have sleep apnea, treating it is probably useful. There's good data on reducing the amount of stress in your life. If you figure that out, please let me know. Things like yoga are useful. And then in terms of food, I think that there's no data that I'm aware of that caffeine is protective. In fact, there is some suggestion that excessive caffeine in some individuals may cause episodes of AFib. There was a recent study, however, that really kind of disproved that. And while there are some individuals who may be very sensitive, the average person is not going to get atrial fibrillation by drinking, you know, 1 or 2 or 3 cups a day. Maybe if you got to 10 cups or more. And then alcohol, I think, is the big issue. It's quite clear that alcohol is toxic to the heart, and there's a clear correlation between alcohol intake and atrial fibrillation. I mean, I try to tell my patients that if you're going to drink, try to stick with a glass of wine or glass of beer, not too often. Try to stay away from hard liquor. But there is data that complete abstinence of alcohol is best.
And so that data about complete abstinence, that's relatively new in the last few years with the American Heart Association and other sources, right?
Yeah. There was a trial that did this, and number one, they had a really hard time enrolling, and number two, they had a really hard time in keeping people abstinent. So while it's great, I do believe that, you know, people live their lives, and then we all make choices. And again, if you're going to drink a glass of wine or a glass of beer, and try not to do it every night.
Great, thanks. And so another question's coming in, and I saw our colleague Babette just answered the email for the project manager for their study is been posted again. And just so everyone knows, you will receive an email after this webinar, and we'll have it there as well with more information about how you can participate in the study if, as you meet all the requirements that Dr. Passman has noted. So I think you kind of talked about this, but let's just make sure. Someone had asked, can you do the pill and pocket anticoagulation with a regular Apple Watch?
I would say no, because, you know, we've studied this. In fact, we just published a paper a few weeks ago where we gave the off-the-shelf Apple Watches to people we knew had atrial fibrillation. They had those loop recorders in place, and it only picked up about 60% of the episodes while you were wearing the watch. So, you know, that's really why we've been working with Apple to design a watch that was more sensitive for this use. The off-the-shelf watch, that irregular rhythm notification, is really designed as sort of a screening tool, and it sort of errs on the side of being more specific than sensitive. So while many people are using it, I think that that's a dangerous thing to do, because you're going to miss a fair chunk of episodes.
Good to know. Now we're getting into genetics. What is the role of genetic variation in heart disease? How does the development of digital health open doors to genetic treatment options for people that do have heart disease?
Wow. Well, certainly, I mean, I'm going to limit my answer to atrial fibrillation because there's a lot of work in that too. And clearly, there are genetic variants that predispose you to atrial fibrillation. And we see this. You ask people who in your family has atrial fibrillation, they'll say, oh, my mother and my father, and they developed it in their 40s and 50s. This is typically a disease that you get in your 60s, 70s, and 80s. When we see families who get it, 30s, 40s, there's a preponderance of genetic causes. The problem is that they are the minority of individuals. And the question is, what are you going to do about it? Right? I mean, we could tell those patients, yes, don't get obese and minimize your alcohol. This is a situation, though, where a digital health technology actually could be ideal for these patients because we know they're a higher risk. And we may want to get those patients a sensitive watch or some other measure to look for atrial fibrillation during an age where we wouldn't even normally do it. So I don't think that it necessarily lends itself, these technologies, to sort of reversing the genetic disease. I mean, we are not there yet, although people are working on those as well. But certainly you could use this technology for early detection if you know that there's a family that's at high risk.
Okay. You spoke about this React AFib study being, I think you said 13 or 12 years in the making. And I wanted to ask, how does philanthropy help you get to this type of a level of research from the federal government? 37 million, that's a big number.
Yeah, I mean, I flippantly threw out that number. What I didn't tell you is all of the steps needed to get to that. So really, we recognized that to get to that point, we would need to lay the foundation of all the work needed to get there. We need to prove so many other things. We would need to, have the technology in place. And even to that, we would need pilot data. So this is a really good example. This whole project started with a relatively modest donation from a grateful patient. And we turned that modest donation into a combination of an NIH grant, which we then had another company sort of meet the NIH funding to allow us to do those pilot studies that I described. And that pilot data then allowed us to make the argument to the National Institute of Health that this was a public health issue worthy of a $37 million investment. So these things never happen out of the blue, right? These things always happen from small seed projects, pilot studies that sort of build bridges to the ultimate question. So we never could have done this, if not for that grateful patient, 12 years ago, that allowed us to begin to accumulate the data that ultimately brought us to where we are today.
That's quite empowering, from my side, because I do work with grateful patients who do give gifts. But I guess the question, I'm sorry, I'm going from my mind here, is for people on the call right now, like they hear and say, oh, you've got all this money, 37 million. Is that sufficient? Or like what we know that the government only does bare bones at sometimes, or what else would you be in need of, or do you have enough money? I guess.
Well, first of all, this is one project that we're doing, but we're interested in looking at the role of AFib in dementia, for example. We're looking at, can we give people devices like a cardiac device early on in their AFib journey and keep them out of the hospital and keep them away from their doctor's office for, an $80 investment. So we're doing lots of things, but, there are still huge unmet needs in this project. That whole watch complication I told you about is something we had no idea we would need. And actually a very generous donor has given us the resources to pay for that. We're really concerned, for example, of making sure that this evidence is generalizable. So how do we get underrepresented minorities into a study like this? Those are sort of unmet needs not paid for by the grant. So there are, believe it or not, after $37 million, still lots and lots of questions that we would like to answer that might benefit from further funding. And as I said, I think that one of the great things about a place like Northwestern is that you could go to a doctor, and I'm sure there are very good electrophysiologists and heart doctors all over. But medicine is constantly evolving, and people contribute in all sorts of ways, and we all benefit from these discoveries. But places like Northwestern are the ones pushing the envelope, right? Asking the questions, why, right? Why would we do it the way we do it now? And so much of what we do in medicine is based on what we think is best, with no data that really questions it. So, I would argue that there are a handful of places in the country that are capable of pushing the envelope like this. And I think, we all benefit in ways either directly for ourselves, people that we care about, patients that we care about.
Thanks. Another question, will there ever be a wireless defibrillator or a pacemaker implant?
Oh, easy, yes. So actually, there's already a leadless pacemaker that can be placed inside the heart. It's about the size of a small bullet, and it's threaded through the blood vessels and placed in the heart. And we have that today. There's also a defibrillator that goes underneath the skin. There are no wires in the heart itself. It's called a subcutaneous defibrillator. And in both those cases, we use them, but we use them in a select patient population. Not everyone is eligible who needs a pacemaker or a defibrillator for those leadless devices. We're also incredibly lucky at a place like Northwestern to have expertise all over the university. So there's a spectacular engineer by the name of John Rogers who designs a lot of monitors, and we're working with John and his group to design dissolvable pacemakers, right? Made out of sort of components you could buy in your supermarket to essentially have a pacemaker for patients who may only need pacing for a short period of time. For example, after valve surgery. It's certainly early stages, but eventually maybe they'll have pacemakers that will dissolve in a few weeks and then be gone. So everything in cardiology is evolving in time. And I think it's one of those fields where technology plays a huge role in the advancements of what we do on a daily basis.
Speaking of technology, that's another question that's come in about artificial intelligence. Is there a role for artificial intelligence in digital health as it pertains to AFib?
Oh, definitely. So, some of those squiggly lines I showed you, as I call them, the PPG signals, we're already using artificial intelligence to define which is a normal rhythm and which is atrial fibrillation. And the watch that we're using with Apple actually uses artificial intelligence to figure out who's having atrial fibrillation. When I showed you that picture of that character checking their EKG to see if their watch is correct, actually, you don't even need to do that in our study because the artificial intelligence that we're using is so accurate in this population that it really doesn't matter what the EKG shows. So I think artificial intelligence already plays a role in automatically reading these devices, but there's also artificial intelligence that can tell from an EKG, even when you're in a normal rhythm, whether you've had atrial fibrillation or not. And there are artificial intelligence projects that are taking people and using their watches, and it will alert you if you're about to have an episode of atrial fibrillation. So maybe in the future, we won't even wait for it to occur. We can predict that it's going to occur.
That's fascinating. And I think we're almost at time here, but I just wanted to give you like a minute to kind of give us like the high picture is that this does affect so many people that are on this call, our loved ones, but that we should, I guess for me, I'm leaving with a sense of hope that there's treatments and that this can be managed and we can have a quality of life with this.
Yeah, I would say that of all of the abnormal rhythms that we treat in cardiology, there's been the most progress made in atrial fibrillation in every aspect. So, there's really little reason these days to be suffering from the consequences of atrial fibrillation or suffering with some of the consequences of the treatment. There's so much that we can do for people at a place like Northwestern. And we're really, happy that we get to work with such great colleagues working with such advanced technology. So there's great hope already in place, but particularly for the future.
Well, thank you. I think we're at time and we'll leave it at that. Thank you to everyone that participated, and you will be getting a recording of this webinar and more information about Dr. Passman and the center that he leads and the research that he is doing. Thank you so much, Dr. Passman.
My pleasure. Thank you.
Thanks.